second lecture in the series on basics of electrocardiography. To start with, we have a discussion on ECG changes in cardiac chamber enlargements. Normal P wave has an amplitude of 2.5 mm and a width of 2.5 mm on the ECG. An increase in the amplitude is an indication of right atrial enlargement, and an increase in width an indication of left atrial enlargement. When both atria are enlarged, both width and amplitude are increased. P wave abnormalities are best assessed in leads 2 and V1. Normal P wave is upright in lead 2. In V1, a tiny initial spike is followed by a shallow negative wave. P mitrale is a nosed and broad P wave with taller second peak indicating left atrial enlargement. It may be noted that initial part of P wave is contributed by right atrium as it is activated first, and the second part by left atrium which is activated later. It is associated with a prominent negative deflection of P wave in V1, the left atrial component. Magnified ECG tracing showing P mitrale in left atrial overload. Tall peaked P wave of right atrial enlargement seen in cor pulmonale is known as P pulmonale. The tall P of right atrial enlargement in congenital heart disease is called P congenitale. P wave axis is rightward in P pulmonale while it is leftward in P congenitale. The initial spike in V1 more than 1.5 mm is also a feature of right atrial enlargement. ECG tracing showing P pulmonale with tall peaked P waves in lead 2. P tricuspidale has been described in tricuspid atresia. The pattern is mirror image of P mitrale. The initial peak is taller than the second peak in P tricuspidale. It indicates biatrial enlargement. P wave from a monitor screenshot resembling P tricuspidale. The P wave is wide and first peak appears taller than the second. While atrial enlargement is manifest as changes in P wave, ventricular enlargements are mainly manifest in the QRS complex. There can be secondary changes in the ST segment and T waves. Left ventricular hypertrophy is divided into left ventricular volume overload and pressure overload. Similarly, right ventricular hypertrophy is also divided into pressure and volume overload. Left ventricular volume overload is characterized by small narrow Q waves, tall R waves with upright and tall T waves in lateral leads. Deep S waves are noted in leads V1, V2. Left ventricular volume overload is noted in mitral and aortic regurgitation as well as ventricular septal defect with large left to right shunt and patent ductus arteriosus. Left ventricular volume overload is also known as diastolic overload. Left ventricular pressure overload occurs in systemic hypertension, aortic stenosis, and hypertrophic obstructive cardiomyopathy. It is also known as left ventricular systolic overload. In addition to tall R waves in lateral leads and deep S waves in V1, V2, there will be downsloping ST segment depression and T wave inversion, LVH strain pattern. Severe left ventricular hypertrophy with strain pattern in severe aortic stenosis. The R wave in V5 and V6 are so tall that they are overlapping with tracings in the channel above. ST segment depression and T wave inversion are seen in inferior and lateral leads. Sokolow-Lyon criteria for left ventricular hypertrophy is one of the commonly used, though not very specific. It can be stated as follows: S wave in V1 plus R wave in lead V5 or V6 more than 3.5 mV, or R wave in V5 or V6 more than 2.6 mV. This is based on tall R waves noted in leads facing the left ventricle and deep S waves in leads facing right ventricle noted in left ventricular hypertrophy. It will correspond to 35 mm and 26 mm respectively, with usual standardization of 10 mm to a mV. Right ventricular volume overload is manifest as RSR prime pattern in V1. incomplete right bundle branch block pattern. This is typically seen in atrial septal defect with large left to right shunt. RSR prime pattern is seen in V1 and V2, suggestive of incomplete RBBB pattern which can occur in right ventricular volume overload. Right ventricular pressure overload manifests as tall R waves in V1 and deep S waves in V5, V6. In addition, there may be right axis deviation of QRS. When there is right axis deviation, deep S waves are noted in lead 1. Right ventricular pressure overload is seen in pulmonary stenosis and pulmonary hypertension. Right ventricular hypertrophy with tall R in V1, deep S in V6 and right axis deviation. There is associated P pulmonale in lead 2 indicating right atrial enlargement secondary to right ventricular hypertrophy. Sharp positive P wave in V1 also reflect right atrial enlargement. Biventricular hypertrophy can be considered if patterns of both left ventricular hypertrophy and right ventricular hypertrophy are seen together. But hypertrophy of one ventricle can sometimes mask the ECG changes due to hypertrophy of the other ventricle. One specific type of biventricular hypertrophy pattern seen in children with congenital heart disease is known as Katz Wachtel phenomenon. In this condition, tall biphasic QRS complexes are noted in mid-precordial leads. This is seen classically in large ventricular septal defect with hyperdynamic pulmonary hypertension. Recordings have to be obtained at half standardization, that is 5 mm per millivolt, to prevent overlap between the QRS complexes of the different leads so that the voltages can be measured accurately. Tall biphasic QRS complexes are seen in leads V2 to V5 in this ECG, suggestive of Katz Wachtel phenomenon. Overlap of QRS complexes between leads above and below are visible, indicating the need for a recording in half standardization. QRS complexes are predominantly negative in leads 1 and AVL, indicating right axis deviation of QRS. Moving on to calculation of the electrical axis. Electrical axis can be calculated for the P wave, QRS complex or the T wave. It can even be calculated for the segments like ST segment, though it is seldom done. Most often, only the average QRS axis is calculated, and when electrical axis is mentioned, generally only mean QRS axis is meant. QRS axis can be altered in various disease states like intraventricular conduction defects, myocardial infarction, chamber hypertrophy, and change in position of the heart. For calculation of mean axis of the QRS complex, the amplitude of the negative waves is subtracted from that of the positive waves while plotting on the graph using lead 1 as x-axis and AVF as y-axis. Another method is to check the lead in which transition from positive to negative QRS occurs using the hexaxial reference system. The axis is perpendicular to the lead in which equiphasic complexes are seen. The axis of lead 1 is taken as 0 towards the left and plus minus 180 degrees towards the right, that is negative pole of lead 1. The axis of AVF is taken as 90 degrees downwards and minus 90 degrees in the vertically opposite direction. Mean QRS amplitude of lead 1 and AVF are plotted along the corresponding axis and the resultant taken as the mean QRS axis. Illustration of determination of QRS axis using lead 1 and AVF. In the hexaxial reference system, each lead is assigned an axis for its positive pole. The negative pole will be diametrically opposite to it. Mean QRS amplitude in each lead is checked to see if there is a lead which is equiphasic. If so, the QRS axis is taken as perpendicular to it. For example, if the equiphasic complexes are found in lead 1, QRS axis is 90 degrees. It will be plus 90 degrees if AVF is positive and minus 90 degrees if AVF is negative. In this case, AVF will show the longest QRS complex as the QRS axis is along this lead. If no lead is seen as equiphasic, leads in between which the QRS transitions from predominantly positive to predominantly negative is checked. Suppose it is between lead 2 and AVF, then the transition is at plus 75 degrees. QRS axis will be minus 15 degrees if lead 1 is positive and plus 165 degrees if lead 1 is negative. Hexaxial reference system used for determination of electrical axis. The positive poles of the leads are marked by the arrows. Normal QRS axis is in the right lower quadrant between lead 1 and AVF. If the axis is in the left upper quadrant between lead 1 and minus AVF, it is taken as left axis deviation. QRS axis up to minus 30 degrees is taken as minor left axis deviation or leftward axis. QRS axis in the right lower quadrant between AVF and minus lead 1 is right axis deviation. At a glance, if both AVF and lead 1 are positive, the QRS axis is normal. If lead 1 is negative and AVF is positive, it is right axis deviation. In left axis deviation, lead 1 is positive and AVF is negative. If both lead 1 and AVF are negative, it is indeterminate or northwest axis. This could be either extreme left axis or extreme right axis deviation. Calculation of P and T wave axis are similar but seldom done and more difficult because of the smaller amplitude of the waves. Difference between the QRS and T axis has been called the QRS-T angle, which is widened in ischemia. Illustration of computerized ECG recording with automatic display of calculated P, QRS and T wave axis in a clock-like diagram beside the measured values in the top panel marked by red arrows. The display also shows the axis of standard leads 1, 2, 3 and augmented leads AVR, AVL and AVF. The numerical values for the P, QRS and T wave axis are given in the measured results in the left upper corner marked by blue arrow. P wave axis is given as 20 degrees, QRS axis as 20 degrees and T wave axis as 10 degrees. Hence the QRS-T angle will be 10 degrees. Sokolow voltage is displayed as 3.6 millivolt. Moving on to conduction disturbances. Sinoatrial conduction abnormality could be first degree, second degree or third degree SA blocks. But it is not possible to identify first degree and third degree SA blocks on the surface ECG as the sinus node activity is not visible. Theoretically, first degree SA block would mean prolongation of SA interval with regular conduction and third degree SA block would mean total absence of SA conduction. Second degree SA block could be either type 1 or type 2. In type 1 SA block, there will be progressive prolongation of SA interval followed by blockage of one P wave. This will manifest as progressive shortening of PP interval followed by a pause. But the pause will not be exact double of regular PP interval. In type 2 SA block, there will be sudden blockage of a P wave so that a sinus pause exactly twice the regular PP interval will be noted. Sinus arrest is a sinus pause which is more than 1.5 times the regular PP interval but not exactly twice the PP interval. There is no preceding progressive shortening of PP interval. Sinus arrest or pause could be a defect in the automaticity of the sinus node. ECG rhythm strip documenting a long sinus pause of around 8.5 seconds. Such long pauses are a manifestation of sick sinus syndrome. Central monitor record capturing a long pause of about 8 seconds and two pauses of around 2 seconds. The underlying rhythm is atrial fibrillation as no P waves are seen and there is some QRS widening with a notch. First degree atrioventricular block is manifested in the ECG as prolongation of the PR interval. Normal PR interval ranges from 120 to 200 milliseconds. First degree AV block is a very common finding and if isolated does not carry additional prognostic significance. But if it is associated with other conduction abnormalities like bundle branch blocks, it gives added significance indicating a more severe conduction system disease. It can be seen in acute rheumatic fever. ECG showing sinus bradycardia with first degree AV block. RR interval is 1280 milliseconds corresponding to a heart rate of 47 per minute, and PR interval is 320 milliseconds. Second degree AV blocks can be either Mobitz type 1 or type 2. Type 1 is also known as Wenckebach phenomenon. Mobitz type 2 block is usually associated with intraventricular conduction defects like right bundle branch block, left bundle branch block, hemi blocks, or a combination of these. Typical features of Wenckebach phenomenon are 1. Progressive prolongation of PR interval followed by a dropped QRS. 2. Progressive shortening of RR intervals. 3. This is because the increments in PR interval are decremental. 4. Pause due to dropped QRS is less than twice the previous RR interval. Mobitz type 1 block is usually more benign and due to AV nodal pathology. Progression to complete heart block is less common. Even if it progresses to complete heart block, the escape rhythm is of narrow QRS and has a good rate. Second degree AV block associated with inferior valve infarction is Mobitz type 1. Conduction ratio in second degree AV block is mentioned as the ratio between the number of P waves in the Wenckebach cycle and the number of QRS complexes. For example, if 3 P waves are conducted and the fourth one is blocked, it is called 4 to 3 Wenckebach block. In Wenckebach type of block, the conduction ratio is always in the form of x plus 1 is to x. That is, only one P wave is non-conducted in any cycle. Highest grade of type 1 AV block possible is 2:1 AV block, in which the ventricular rate will be half that of the atrial rate. That means 50% of the P waves will not be conducted. In Mobitz type 2 second degree AV block, there is no progressive prolongation of PR interval. Instead, there is an abrupt droppage of a QRS. Hence, the pause is exactly twice the previous RR interval, and there is no variation in RR intervals except for the pause. There may be no prolongation of baseline PR interval. Mobitz type 2 block usually originates below the His bundle and, as mentioned earlier, is associated with other intraventricular conduction defects. Mobitz type 2 block carries a more sinister prognosis as the escape rhythm which occurs if it progresses to complete heart block is of wide QRS, lower rate and unstable. Location of the block is below the bundle of His or infrahisian. In this ECG, there are 2 P waves for every QRS complex with atrial rate double that of ventricular rate, denoting 2:1 AV conduction or 2:1 AV block. In addition, there are features of left bundle branch block suggesting infrahisian block. Left bundle branch block is indicated by wide slurred QS complex in lead V1 and wide slurred R waves in lateral leads. Typical M pattern is visible in V5. T waves are concordant in lateral leads, that is, T waves in same direction as QRS. This indicates a primary T wave abnormality. T should have been opposite to QRS in left bundle branch block. When 2 or more consecutive P waves are non-conducted, it is termed advanced AV block. Advanced AV block is midway between usual second degree AV block and complete AV block. ECG showing advanced AV block with RBBB. PP interval is 480 milliseconds, corresponding to an atrial rate of 125 per minute. PR interval is relatively fixed at 440 milliseconds for most of the conducted beats, though the conduction ratio varies between 3:1 and 2:1. That is, 2 P waves visible between second and third and fifth and sixth QRS complexes in the rhythm strip marked in red color. Some of the P waves are overlapping with QRS complexes. 2 of them, which are clearly visible, have been marked in green color. Others are fully within QRS, so that their presence should be inferred based on the regular PP interval. QRS complex is wide with RS R prime S prime pattern in V1 and slurred S waves in lateral leads, indicating right bundle branch block. Q waves and T inversions are noted in inferior leads. In the setting of inferior wall infarction, as evidenced by Q and T inversion in inferior leads, though suprahiscent type of block, that is type 1 block, is more likely, presence of RBBB would indicate a type 2 AV block. Intracardiac electrophysiology study is needed in this case to delineate the exact mechanism of block. In complete AV block, there is no relation between atrial and ventricular rhythms and they are completely dissociated. The four classical ECG criteria for diagnosis of complete AV block are 1. Regular PP interval, 2. Regular RR interval, 3. PP interval shorter than RR interval, that is atrial rate more than ventricular rate, 4. Totally varying PR interval indicating AV dissociation. Though the PP intervals and RR intervals are usually regular, there could be some variations occasionally. If there is an occasional conducted beat, the ventricular rhythm can show irregularity. Junctional focus can have slight variation in rate due to autonomic influence. Atrial rates can show two types of sinus arrhythmia. In respiratory sinus arrhythmia, PP interval shortens during inspiration as the rate increases and lengthens during expiration as the rate decreases. In ventriculophasic sinus arrhythmia, a PP interval enclosing a QRS complex will be shorter. This is thought to be due to the mechanical effect of ventricular systole causing enhanced pulsation of the sinus node artery penetrating the sinus node. It has been shown that the ventriculophasic response can be enhanced by deep inspiration, like in case of sinus arrhythmia. The location of block in complete AV block can be either above, that is suprahischian, or below the bundle of His, that is infrahischian. In suprahischian block, the QRS complex is narrow and has a relatively higher rate as it arises from the lower part of the AV junction. In infrahischian block, the subsidiary focus is from the ventricle and has a lower rate with wide QRS complex. The subsidiary rhythm in suprahischian AV block is more stable than that in infrahischian block. Hence, there is a higher chance for Stokes-Adam attacks with infrahischian block. In the setting of acute myocardial infarction, suprahischian block is usually noted with inferior wall infarction and infrahischian block is associated with anterior wall infarction. The latter is often associated with significant left ventricular dysfunction and poorer prognosis because of the large area of myocardial damage involved. Suprahischian complete heart block in inferior wall infarction is usually reversible. Infrahischian complete heart block in the setting of anterior wall infarction is more likely to be permanent. Even if there is partial recovery, very often bundle branch block or fascicular blocks remain. References on ventriculophasic sinus arrhythmia. ECG tracing showing severe bradycardia due to complete heart block. RR interval is 1.8 seconds corresponding to a ventricular rate of 33 per minute. PP interval is 720 milliseconds indicating an atrial rate of 83 per minute. The T waves are very broad and the QT interval is prolonged 760 milliseconds indicating a risk for a type of polymorphic ventricular tachycardia known as toss at the points and Stokes-Adam attacks. This is a high-risk ECG pattern. Next video in this series will start with supraventricular arrhythmia.